Shukran, Dr. Nizar. It's a great pleasure to be here with you today for the people online and for the few people here in the audience. So the objectives of my talk is to shed light on the epidemiology of respiratory viruses in our region and worldwide, how vaccination affected the seasonal respiratory infections and respiratory viruses vaccines, which we used to call the triple-demic, the RSV, influenza, and COVID-19. We will just talk briefly on each one of them and the vaccination efficacy. So respiratory viruses in general is a worldwide leading cause of morbidity and mortality. It affects mainly young children and elderly, especially in middle and low income countries. The estimated incidence of death is about 2 to 5 million of cases and more than 300,000 deaths yearly. The most common respiratory viruses families are those ortho and paromyxiviridae, picornaviridae, coronaviridae, adenoviridae. So most of the common viruses that we see on daily practice belong to those 4 families. They are transmitted through 4 ways, either droplet, airborne, contacts, or indirect through the fomites. The chances of transmissions depends on many factors. The most common factor is the pathogen. If the virus is non-enveloped, like the rhinovirus, the chances of getting there on the surface for a very long time is high. While the enveloped viruses like the RSV and influenza is very susceptible to disinfection and degradation. So it stays on the surfaces for a few minutes and maybe hours. Of course, there is the host factor. If the host is child or elderly, immunocompromised or immunocompetent, and the environment factor like the temperature, humidity. That's why we see the seasonal variation between the northern and southern hemisphere. Influenza, human COVID, and RSV is common in winter, while rhino and parainfluenza is common in autumn and spring, and noroviruses like the summer. And some viruses are present all year around. The seasons, of course, are reversed by the hemisphere. And in tropics, tropical area, the RSV and influenza is more common during the rainy season. There is a theory called the domination theory, where you can't see 2 peaks of viruses at the same time. This was studied theoretically, but for example, if you see influenza and RSV, one of them will peak, then it will, there is rarely to be overlapped. And the main reason is due to the receptor and the host interferon production. Clinical syndromes varies from all over, from the upper respiratory down to the lower respiratory, and the entrance is usually eyes, nose, or mouth. So you can see here it can affect all parts of the respiratory system, from common cold, pharyngitis, laryngitis, tracheitis, bronchitis, then most commonly pneumonia, and it can cause also extrapulmonary disease, as we will talk further. The first virus that we will shed light on is the influenza. It's very susceptible for epidemics, and maybe there is a talk today in about from pandemic to epidemic, I think also COVID-19. It's an enveloped virus, single-stranded, belongs to the orthomyxiviridae virus. The incubation period is, as any other respiratory virus, is 1 to 3 days or 4 days. It has constitutional symptoms. Atypically in adult and elderly can cause confusion. Children may present with GI symptoms. The highest risk are those younger children, elderly, and immunocompromised. Complications are on the right side. It can cause a neurological, like Reye syndrome, meningitis, Guillain-Barré, cardiac all over, myocarditis, epicarditis, or pericarditis. Respiratory, of course. Pregnancy can cause abortion or low birth weight. Musculoskeletal can cause rhabdomyolysis and myositis. We see often myositis in children. This is the estimated burden of the disease: 9 million flu illnesses, more than 100,000 hospitalization, and more than 5,000 deaths per year. Over a decade in US, this is the burden of influenza. If you see the triangles, the illnesses are still there, hospitalization is still there, and also deaths are still, so it still carries a burden of disease. Just a brief about influenza. Influenza is a very complex virus. It has many subtypes like influenza A, B, and C. A is the most complex and the most virulent because it is subjected to shifts, and shifts can cause pandemics. It has many genes, up to 8 genes in each type of virus. It can spread to humans and others like animals. Influenza has the N protein and H protein, the neuraminidase and hemagglutinin protein. The neuraminidase protein is responsible for the virus to get it out of the respiratory tract, while the hemagglutinin is envelops the virus to allow the virus to enter the cells. So influenza virus is subjected to drift or shifts. The shift cause pandemic, as we said, and drift can cause epidemic only. The influenza A can cause pandemic and shifts. This is in the Eastern Mediterranean region. This is the cases per week, the positivity per week. As you can see here, during the winter season, we always see spike, and mainly in B subtype. So this is also in EMRO region. B is the most common, followed by A, H1N1. So why it is very difficult to make flu vaccine, and every year there is a changes in flu vaccination, because it has the 3 types as we mentioned. It has the genes, the H and N proteins as well. So we have almost 18 H and 11 different N protein. And if you combine each of them, you can get up to 144 different combination of H and N. So we need to target those H and Ns and to cover all types of virulent viruses. These are the most host susceptible to severe influenza. This is by the age, elderly, of course, children below 6 months of age, diabetic, cancer, immunocompromised, COPDs, also pregnant ladies and healthcare workers and residents in nursing homes. This diagram is interesting, shows you how the virus progress and how you can stop it. The vaccine can ameliorate the disease, the treatment can ameliorate the disease, but this can cause up to a death from upper respiratory, mild, moderate, then lower respiratory, also extrapulmonary. These are all depending on the viral factor, viral load, host factor like the age and immunity of the factor. The vaccine has many types. We have the live attenuated. We don't have it here in Saudi Arabia. We have and the inactivated influenza vaccine. The live is given through nasal spray. We have the trivalent and quadrivalent. We prefer quadrivalent. We have the egg-based, culture-based, egg-free, and recombinant, all recommended. And we have the high-dose adjuvanted, and it's recommended mainly for elderly because the elderly is they don't produce good immune response. So high dose produces 4 times immune response in more than 65 years of age, as well as the adjuvanted. So these are the options based on the age. You can see here, if you concentrate above 65 years of age, we give the adjuvanted or the high dose, which is called the fluid quadrivalent. We have many companies that provide the vaccine like Sanofi and others. The live, we can give it only between the age 2 to 50 years of age because of the side effects, possible side effects, and we give it by mist or nasal spray. So the main aim of the flu vaccine is to prevent influenza, but we're not only preventing influenza, we are reducing the complications like hospitalization and death. This is the main difference between the vaccine efficacy and vaccine effectiveness. Effectiveness is real-world data when you see the effect on the patient, but the efficacy is in clinical trial where you see the effect of vaccine on the ideal situation. So we measure the effectiveness mainly, especially in those respiratory vaccines. This is the effectiveness. You can see the effectiveness of the flu vaccine all over from 2010 up to today. The vaccine efficacy or effectiveness ranges between 40 to 50%. So the average of efficacy is 55%. It varies by the season, of course. The immunity lasts for 6 months, but it starts to wane after 4 months. The vaccine wanes faster in elderly, more than 60 years of age. This is from the Lancet. It shows the pooled efficacy is 59% of the inactivated vaccine. And for the live attenuated, in children, the pooled efficacy is up to 83%. So the live attenuated in children is more efficacious than the inactivated in adults. For the maternal immunization, that's why we are advising the pregnant ladies to get the influenza every season. So it protects the child up to 6 months, and the efficacy is 63% for the infants. So the latest vaccine recommendation between 2023 and 2024 season, the main update was in the H1N1 segment. That was about the influenza. RSV is the now the talk of the town, as we everyone is talking. So RSV causes caused by type A or type B. There is no much difference between type A and B. There is seasonal variation, but either say you can get type A and B. There is no much in clinical presentation. It's an RNA, causes upper respiratory or lower respiratory in all ages. Transmitted mainly by droplet, can be by contact. The R naught is 3, which is high, considered high. The R naught for COVID, as we know, is only 0.5, but for RSV is 3. So one person can infect 3 if he is in active disease. So in children, we see it in our daily practice: acute bronchiolitis, sometimes ICU admission, ventilation, and etc. But we have to know that RSV can cause a severe disease in all ages, mainly in elderly. We don't have treatment. Treatment is supportive. We used to give ribavirin before, but it's not that effective, and it has many side effects. So the main thing is to prevent and to give the prophylaxis. This is the age-wise distribution of RSV globally. If we compare it to the influenza, influenza is in the orange line, and the RSV is in the blue line. So it's quite active, especially in those age groups that we mentioned. This is differentiation between RSV, COVID-19, and influenza. You can see RSV spikes mainly in December and February, the blue one. This is the burden of the disease: up to 2 million outpatient visits among children and younger than 5 years of age. The hospitalization is up to 80,000, less than 5 years of age. And in older adult, also up to 150,000 hospitalization per year. Death is up to 10,000, and also the deaths in children. The deaths is more in elderly, more than children. These are the high-risk group: COPD, cardiac, renal disease, diabetic, all comorbid. Also, the ones in nursing home are at high risk. In Northern Hemisphere, you see this by temperature zone, you see the peak in January, but it can stay up to May. We saw RSV in May, also in June. In regard to prophylaxis or prevention, we had palivizumab since many years. We give it to children with high risk, like premature and cardiac. We give it for 5 doses. It's very expensive. It's very difficult to bring the child 5 times, and he is immunocompromised to the clinic. Now we have a new monoclonal antibody called nirsevimab. It's a 1-dose dose, and it has high efficacy up to 6 months. It's not yet available in Saudi Arabia, but it's within the approval. And we have the RSV vaccine that started to be in Saudi Arabia, and Ministry of Health adopted the GSK vaccine. So the structure of the RSV vaccine is very simple. We have the F protein and the G protein, which is the fusion and glycoprotein. One is attached to the ciliated epithelium and ciliated airway, and the other one to the epithelium. This is the differences between the RSV 1 and 2. There is no much differences. This is the recommendation of the vaccine. I was really excited to have a maternal vaccination adopted by Saudi Arabia, but it's not yet. The one is authorized or licensed for Saudi Arabia is the adult one only. They did not authorize the Pfizer. So we have the two RSV vaccine, one from GSK and the other one from Pfizer. This is for 60 years of age and older. GSK has comorbid data, which is superior to the Pfizer one. Pfizer is only authorized for pregnant ladies between 32 and 36 years of age. And of course, we have the antibody, the nirsevimab, and the other one. When to give it? For infantile children, you can give it between October and up to March. It's a 1 dose. For pregnant ladies, it has to be in between 32 and 36. So this is a very narrow window for pregnant ladies. It's very difficult to convince mothers for any vaccine. What about if you have very narrow window? So this is might be challenging for the obstetrician to convince the pregnant ladies. Lastly, we have the two vaccines that are eligible for more than 60 years of age, and it's protective for more than 2 years. So there is no indication to give it in the next season. The efficacy is very high, or effectiveness, up to 97%, 98% in all types of the vaccine. So this is really promising. Lastly, I will not mention a lot about COVID-19 because we've had enough from COVID-19 in the past 3 years. But as we know that SARS-CoV belongs to the coronaviridae. Coronaviruses are known since very long time. We have the HCoV and L63, but the most, the ones that got the halo effect is the SARS-CoV and the MERS-CoV because of the pandemics. We cannot forget this. So this is the positivity rate from the PCR and the death rate up to February 2024. So you can see the death rate in the blue is decreasing, but still we have positive cases and still we have death rates. If we compare the cases between Singapore, Saudi Arabia, and the United States, Saudi Arabia is in a good shape. United States, still we have cases, and Singapore, we have spikes nowadays. This is the accumulated death rate between India, Saudi Arabia, United States, and Singapore. Also, the curve is plateau in Saudi Arabia, so death rate is controlled. But COVID-19 is still a threat. It's not over yet, so we have to be careful, especially in high-risk group. These are the high-risk group. The one who did not receive any vaccine, they should get a vaccine, the COVID-19 vaccine. And the one who got at least 1 dose, they should take another dose after 6 months of the last dose if they are high risk. And these are the high risk. These are the high priority group, older than 75 years or older, or 60, more than 60 with comorbidity, pregnant, so they should take the vaccine. The medium priority group is the healthy adults and the children and adolescents with comorbidity. Low priority, they should not take it, which is the healthy children and adolescents. Healthcare workers are considered high risk, so they should take the vaccine after the last dose 1 year later. Just a summary of all vaccines during the season. You will take COVID-19, influenza, RSV, and that's it. Thank you very much.